Hello, I'm Dr. Nate Pennell, your guest host today for the ASCO Daily News podcast. I'm the co-director of the Cleveland Clinic Lung Cancer Program and vice chair of clinical research at the Taussig Cancer Center, and I also serve as the editor-in-chief of the ASCO Educational Book. My guest today is Dr. Christopher Booth, a professor of oncology and health sciences at Queen's University in Kingston, Ontario, where he also serves as the director of the Division of Cancer Care and Epidemiology. He joins me today to discuss his recently published article in the 2024 ASCO Educational Book titled Common Sense Oncology, Equity, Value, and Outcomes That Matter. Dr. Booth also addressed this topic during a joint ASCO European Cancer Organization session at the 2024 ASCO annual meeting. Dr. Booth, welcome. Thanks for joining me.
Thanks for inviting me here, and I look forward to our conversation.
So, in your article in the educational book, and again, thank you so much to you and your co-authors for writing that for us, and during your presentation at the ASCO annual meeting, I think your topic really resonated with a lot of people. You explained that the essence of oncology is delivering compassionate care, and I really was struck by the statement that treatments need to provide meaningful care, meaningful improvements and outcomes that matter, regardless of where the patients live. Can you just tell us a little bit, what exactly is Common Sense Oncology? What's your vision for what it can do to help address some of our growing challenges today?
Thanks, Nate. So the Common Sense Oncology Initiative was launched just over a year ago, and it really was, a grassroots gathering of clinicians, policymakers, academics, as well as patients and patient advocates who recognize that there's many things we do well in the current cancer care system, but there's also areas that we can improve. And so it was created as a space for us to advocate for greater access for the things that we know really help people, but also to create a space where we can be willing to have some tough conversations and some self-humility and look at within our field about some of the things that maybe aren't working as well as they should and try to be constructive and not just critics of the system, but actually be solution focused and to try to move things forward. So that the Common Sense Oncology Initiative, which has really taken off over the last year, really brings together people from all health systems who care deeply about people and their families who are with cancer. And our mission is that cancer care systems deliver treatments that have outcomes that matter to patients. And the vision is that, as you stated in your introduction, that regardless of where someone lives, they have access to those cancer treatments which really do make a difference in their lives.
That certainly sounds like something everyone should be behind. Before we talk about some of what Common Sense Oncology may be doing to help address some of the inequities in cancer care, one of the challenges that is addressed in your paper is the focus on modern clinical trials and perhaps some of the mistakes that we're making in how they are designed. In many ways, we sort of live in a golden age of clinical trials with biomarker-driven treatments, which can be incredibly effective in small populations of people, sometimes at great expense. So focusing on our modern clinical trials, some of the criticisms that have arisen are that perhaps the endpoints that are being designed really aren't ones that are meaningful for patients or that the gains that they're trying to look for in these trials may not be particularly meaningful. So talk a little bit about that, if you might.
One day I might write a book called, Paradoxes in Cancer Care, but there's a number of these things I think about. I'll start, Nate, in response to your question by talking about something I think of called the three buckets paradox. The three buckets paradox, I think, reflects a communication failure on the part of our field, whereby if a patient or a member of the public only reads the newspapers about cancer, they might wonder why we even have cancer hospitals and why Dr. Pennell and Dr. Booth even have a job, because everything we're doing is curing cancer. But we know the reality is different. And so I conceptualize cancer treatments as going into three different buckets. We have the red bucket, which are those treatments which really are transformational. And I've been working in oncology for 20 years now, and we've seen a number of these treatments. They markedly increase cure rates or help people live for many, many months or extra years of life. And we have those treatments. They're almost out of a science fiction movie. The green bucket is a series of treatments. They're not perhaps transformational, but they're very, very good. They offer substantial benefits to our patients, and we have quite a few of those. The concern that I think many of us recognize, and also just to state emphatically that the problems that CSO is thinking about, these are not new problems. I think every oncologist has struggled with these things throughout each of our own careers. The concern is the third bucket, which includes many of our newer treatments, some of which, of course, are transformational, but many of the new treatments fall into this bucket, which they have important side effects. They have major financial toxicity for patients, families, and the system. They have time toxicity, especially in the last year of life. And the reality is, most of these new treatments, either there's no proven benefit, they help people live longer or better lives, or if they do, it's measured in a number of weeks. So I think we need to reconcile the fact that we need to maybe speak honestly about some of the challenges in our field to recognize there's probably too many treatments going into that last bucket. And we need to push harder in the research ecosystem and in the policy space to ensure we have more treatments in the first two buckets and that they remain widely available to everyone. So to get to the specific issues you raised in your question, Nate, some of the effect sizes and the endpoints we're choosing are problematic, I think. We have many, many examples of incredible clinical trials and new treatments that really make a difference for the lives of our patients. So I want to state emphatically that the RCT remains the best tool we have to identify new treatments for patients of tomorrow. And any challenges with clinical trials, actually, it's not the fault of the RCT. These are self-inflicted by us who design, interpret, and act on clinical trials. And so the use of surrogate endpoints is a major issue in our field. And I just want to also state emphatically that there are circumstances where surrogate endpoints make a lot of sense and we should be using them. The problem is, I think, with our excitement to get treatment answers more quickly, we've really embraced surrogate endpoints in a very, very rapid way. And in fact, I shouldn't even refer to them as surrogate endpoints. Maybe we should use the term alternative endpoints because in many cases, they have been found to not be valid surrogates for those things which we know matter to patients' overall survival and quality of life. So certainly there's a place for surrogate endpoints. I think we live in an era now where the majority of clinical trials are being designed to detect improvements in progression-free survival rather than overall survival. So historically, most clinical trials were being launched to see if we could help people live longer or feel better. Now, the default endpoint is progression-free survival, which largely is based on tumor measurements on a CAT scan. And certainly, there are circumstances where those tumor measurements do relate to how someone feels or how long they live. But in most circumstances, that's not the case. I think we need to take a step back and just see, the big picture here about where is it that we're going and how can we raise the bar and ensure that we're identifying treatments that really offer meaningful gains to patients, because we have to be honest over the fact that the patients and families are the ones who need to live through the side effects, the time toxicity, and financial toxicity of these treatments. So this is about maybe raising the bar and aiming a bit higher than we currently are.
And it looks like CSO basically is putting together teams around evidence generation, evidence interpretation, and evidence communication that I guess is trying to advocate and influence this.
Yeah, so when we launched this initiative, which now is, this large global coalition of people, we want it to be really solution focused. So our work stream is oriented around trying to improve how we generate evidence, how we interpret evidence, and how we communicate evidence. So the evidence generation work stream is being led by a series of leading clinical trialists from all over the world, together with patients and patient advocates who are looking at how we can come up with a framework and principles to design perhaps a more thoughtful approach to the design, reporting, and conduct of clinical trials. So that's kind of a clinical trials work stream. And I should mention all of these project teams are populated by clinicians, academics, members of the public, as well as patient and patient advocates, who in some cases are co-leaders of the work streams. The evidence interpretation work stream is an educational bucket being led by clinicians and educators together with patients to see how we can improve the skill set of the next generation of oncologists to be better equipped in skills in epidemiology, critical appraisal, and critical thinking, so we can better dissect trials which have been well designed from those which might have some limitations, identify those treatments which have very substantial gains from those which are perhaps more marginal. And then the third work stream relates to how we communicate evidence. And this is communication broadly, how we talk about these very complex and nuanced issues at the bedside between oncologist and patient, but how we talk more broadly in society, through the media, with public and policymakers about some of the challenges in cancer care, recognizing, of course, that no one individual group or person is going to have the answer for what treatments matter for any specific patient. This is going to vary by every patient with their unique values, preferences, and goals in life. But we think we can do a better job of talking about these issues and empowering patients to have the information they need so they can make the treatments that match their own goals and wishes.
Oh, thank you. Another thing that I was interested in your paper, and when we talk about value and whether these endpoints that are being released for drugs that become approved are meaningful to patients, The other aspect of value is, of course, the cost. And we know that basically every new drug that gets approved, it's just an astronomical cost these days, which doesn't often factor into whether to approve them. It doesn't often factor into doctors' decision about whether to use them. Can you talk a little bit about this? And is cost of drugs something that CSO is interested in addressing, or is that really more of just a part of the equation in determining value of these?
No, I think it's a really important point. So, the value construct, I'm not an economist, so I think about this, as a simple Canadian chemotherapy doctor would, which is the interface of what you get. So the magnitude of benefits, that's the endpoint and the effect size, relative to the downsides, the cost, the clinical toxicity, time toxicity, and financial toxicity. So historically, I think, Nate, you and I remember maybe 10 or 15 years ago when this really came on the scene, all the conversations focused on the denominator, the cost of cancer medicines, which became astronomical over the last 10 or 20 years. And we've learned a few things about that over time, and I'll get to that in a moment in reference to your question. But I think as individual clinicians or investigators or even people writing guidelines, we don't have a lot of ability to influence the price of cancer medicines, although I think we still need to speak out about these prices, which are largely unjustified. I'll come back to that. But where I think there's growing interest, and we've seen this in the last 5 years, is the numerator in that value construct, which is the magnitude of benefit, the endpoint, the effect size. And I think that's where we actually have much more ability to influence. We are the doctors who make treatment recommendations, the experts who write guidelines, the investigators who design trials. And so I think we need to take a bit more ownership when it comes to this magnitude of benefit construct. And that's where a lot of the work that Common Sense Oncology is doing rests. But to answer your question about cost, this is a major problem. We've known that it's been shown by several groups that the price of a cancer medicine is not justified by the R&D cost. That's been shown over time. We also have a problem where the magnitude of benefit offered by that drug also has no bearing to the price. And so this speaks to the need to really, I think, undertake more rigorous health technology assessment and think very carefully about, in every other economic model that you and I live in, Nate, if, we have a growing family, we need a larger apartment or house, we spend more money, we get a bigger house. If we want to keep up with our kids on their fast bicycles, we spend more money, we get a better bicycle. And when it comes to cancer medicines, we found that not only is there no relationship between how well the drug works and its price, our group and others have found, if anything, there's an inverse relationship whereby the drugs with the smallest benefit have the largest price tag. And I don't think you need a PhD in economics to know that is an incredibly broken system. So I think there's a lot that we need to talk about when it comes to cost. Common Sense Oncology cares deeply about this because it's a huge issue about health justice and global equity and access to cancer medicines. And I think we need to work on that. But we also can't forget about the numerator, which is to what extent do these treatments help people?
Yeah, I know that every time I see one of these fabulous new presentations at ASCO plenary or something like that, I just imagine many of the doctors and patients who live outside the US, maybe in low and middle income countries who don't have the same access to basic oncology care and specialty oncology care that we do in Western countries, and what goes through their minds when they think about this. And so I know that this is another big part of what CSO is doing, is thinking about global equity and access to cancer care. And so can you tell me a little bit about how you're hoping to address that?
Yeah, and so you're right. We have this. This is, I guess, I'll tell you another Booth cancer paradox. So I call this the cancer medicine paradox, which is, on the one hand, in many health systems, I think will recognize that there's often overutilization of cancer medicines that are toxic, expensive, and small benefits, especially in the last year of life. So we have that kind of overutilization paradigm in some parts of the world, but we also have this paradox where we have massive underutilization of those treatments that we know actually have large benefits. And the tragic part of this is many of those treatments are old generic drugs that actually should be very affordable. So some of this work comes out of myself and a number of my founding colleagues of Common Sense Oncology have a policy role with the World Health Organization Essential Medicine List. And my interest in this started, I guess, many years ago when I had a sabbatical in India and lived and worked at a large government cancer hospital for a period of time. And so from this WHO working group, we launched a project. It's been called the Desert Island Study. And so it was called the Desert Island Project for reasons I'll tell you in a moment. But essentially, it was a survey of 1,000 oncologists on the front lines of care in 82 countries worldwide. And what we were interested in doing is, in our role as an advisory group to the WHO Essential Medicine List, we come up with a list of those medicines which are really most important and should be provided in all health systems. And we were interested in going to the front lines of care, leaving the boardroom of Geneva and going to the front lines of care and asking real doctors in the real world, what medicines do you think are the most important for the patients that you look after? So it was a survey. We asked a lot of demographic questions about their clinical practice and their health system, but we called it the Desert Island Project because the core question of the survey was based on the thought experiment that you and I have done many times with friends at dinner parties. For example, if you're moving to a desert island and you could only take 3 books, what would those books be? If you're going to have dinner with any famous podcast host in the world other than Dr. Pennell, who would that person be? And so the thought experiment was, imagine your government has put you in charge of cancer care for your country. You can choose any cancer medicines you want that will be freely available for all cancers and all people in your country. Cost is not an issue, but you can only choose 10. You can only choose 10 of those medicines to take to the desert island to look after all the people in your country. What would those medicines be? And it's amazing, of those 1,000 oncologists, we found, first of all, remarkable convergence between doctors, regardless of where they work, whether it was a high income country, middle income country, lower income country. The doctors were very pragmatic. When we looked at the drugs that went in that suitcase over and over again, the most common drugs were the good old fashioned cytotoxic chemotherapy drugs and hormone drugs we've been using for 20 or 30 years that we know have very, very large benefits. And in the modern era now should be very affordable because they've been off patent for many years. In that list of medicines that went to the desert island, there also were some of our newer drugs that are new and they're very expensive, but there are those drugs that have very large benefits. And of course, all of us would want access to those for our patients. So we found that, the doctors are pretty pragmatic about which medicines, if they're pushed to, offer the largest benefit. But the next part of the question was, okay, you've told us which medicines you want to put in your suitcase to take to the desert island. Please now tell us the reality in your health system. To what extent can you deliver these medicines? And it was shocking. The vast majority of oncologists, a huge number of them said they could not even provide doxorubicin or cisplatin without causing major financial toxicity for that patient and family. Even for trastuzumab, now available as a biosimilar, only 15% of oncologists globally said they could provide it universally to all women with breast cancer. 2/3 of oncologists said, look, I can give it, but I will catastrophically ruin that patient's family's finances for generations to come. So we have a big problem in the sense that we need to focus on those treatments which make a big difference and ensure that they're available to all patients who could benefit, while at the same time raise the bar so that the modern treatments that we're offering also have large benefits.
I think that's really eye-opening, and I hope lots of people take away from this that this is the reality for a lot of, huge number, potentially billions of people on the planet that don't have easy access to the same kinds of drugs. We're not even necessarily talking about the expensive drugs with, the 3-week PFS benefit, but ones that actually could be curing them of their breast cancer and their testicular cancer and their lymphomas. And they can't even get access to those, even though here we might say that they're inexpensive and relatively accessible. So how do we fix that? Maybe this is too big a question for a few minutes in a podcast, but I'm curious to see what CSO is doing to try to help.
Well, the challenges are substantial. And so that's why we've kind of created this group, because it's going to require kind of the collective input, I think, of everyone in our field and beyond. And I also think, one of the reasons we've been overwhelmed with interest by the next generation, the trainees, the young oncologists who are very interested in this. And I think they're recognizing that this might be an alternative place for them to put their energy, talent as they build their own academic careers, is tackling some of these really, really tricky problems where the solutions are not immediately obvious. One thing I think, Nate, that's important is for us to talk about these things and recognize that there's a range of cancer treatments and that this might help set better expectations for the patients and families when they walk into our cancer centers, let alone in the US and Canada, but also globally. We've seen challenges with, all of us as human beings are technophiles. We're drawn towards the new shiny targeted therapy or a robot or treatment in cancer care. And we've seen that play out somewhat tragically. Some of my friends and colleagues in LMICs have told stories where the Minister of Health is about to make a major investment in cancer care, but they want the shiny new monoclonal antibody because that's perceived as being newer and better, when the reality is that might add, 2 months of PFS compared to other agents that are have much larger benefits and, of course, are much more affordable. And there's modeling where even just one of these new medicines for one cancer would wipe out the entire cancer medicine budget for that country, yet we don't have tamoxifen, doxorubicin, cisplatin, or even morphine for palliative care available. So some of this is about socializing these issues, talking about these things that, again, these are not new problems. I think every oncologist worldwide has wrestled with these things, but just at least creating a space where we can talk honestly about this and work towards solutions.
Yeah, no, I think even just having the framework and the awareness and getting people involved is going to make a big difference. And of course, the people who ultimately are impacted the most by this are the patients with cancer. One of the big aspects on your paper is talking about how patients and patient advocates are central to the CSO movement. So tell me a little bit about how they became involved and what role they play in CSO.
Yeah, so this has been a very intentional and deliberate part of the building of the Common Sense Oncology Initiative. So this started with a planning meeting, a very small planning meeting of 30 people in Kingston here at Queen's University just over a year ago, with 30 people from 15 different countries, a mix of academics, clinicians, editors. And in that room were 5 or 6 patients and patient advocates from day one, because we wanted to make sure that this is really all about their needs and creating a system that revolves around the outcomes that matter to patients and families. So since then, we've continued to engage broadly. We have a patient priorities project team. There's co-leadership there. One is a colleague, an oncologist from New Zealand, but the other co-leader is a patient advocate from a breast cancer patient advocate from the United States. And all of our project teams have patients and patient advocates as part of their membership. The patient priorities team is working to design a patient charter to guide the design and implementation of clinical trials from the patient's perspective. And as part of that exercise, we've been undertaking, we call it a CSO speaking and listening tour, where we've had a series of webinars with patient advocacy groups from all over the world, where part of the webinar is us talking about the CSO mission, vision, work stream, and some of the challenges and solutions we see, so that we can provide some education, but also get honest feedback from the front lines to learn kind of where we might be off, what we might be missing, what we should focus on. But then also the second part of the webinar is about sharing this kind of draft patient charter and getting more broad input from patients and families about what it is they're looking for in a cancer system. And I can tell you that some of the most gratifying correspondence I've had since launching CSO, which has been, essentially become my third full-time job, is letters from patients and family members of former patients who have since deceased or active patients on treatment, who are saying how much they appreciate this work and how much they feel that oncology can perhaps do a better job talking about some of these things. And they've been giving us some very good ideas and suggestions that, in fact, I'm already incorporating into my clinical practice. Because ultimately, all of us came into this field to help people with cancer, and I think they can and should and are remaining the center of everything.
I think thankfully that is a movement throughout medicine, certainly cancer medicine, that patients are becoming more involved much earlier in the process of designing trials. And hopefully that alone will help change the endpoints that we're building into these studies to make them much more meaningful. So people are going to read your paper. They're going to get excited. They're going to listen to this podcast. They're going to get even more excited about how they're going to change the world through a little more common sense. So how can they get involved? Is this something that you're open to people working with you? Are there other things people can do to try to help change some of these frustrating problems?
Yeah, absolutely, Nate. So we have a website, commonsenseoncology.org. Some of our co-leaders are very active on social media, so they can follow us through social media channels. If you go to our website, there's a membership button where people can join. There's no fee, and we won't bombard you with too many emails. But what that has allowed us to do is build this network of people who have diverse interests and skill sets that we can then tap into various projects and work streams where we could use the help and support. And members have access to things like virtual webinars, journal clubs, critical appraisal sessions, and they get a newsletter from us every 2 or 3 months about activities and about ideas, and allow exchange of dialogue going back and forth. So certainly we look forward to growing this initiative, and the challenges are large, but we think that, with the collective input of stakeholders from around the world, we can make a difference in moving towards some solutions.
And for our listeners, that is commonsenseoncology.org. You can go check this out and join if you are interested in learning more. So, Chris, thanks so much for sharing your insights and for all of your work on addressing these complex challenges in cancer care.
Thanks, Nate. Grateful for the interview, and also for ASCO for giving us the opportunity in the educational book and at the annual meeting to talk about this work. Thank you.
And I also want to thank our listeners for joining us today. You'll find links to the article discussed today, as well as Dr. Booth's presentation at the annual meeting in the transcript of the episode. Finally, if you value the insights that you heard on the ASCO Daily News podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.